supposed to talk about the indications for treatment, and I still have a disclosure slide up there, not particularly, hopefully impacting what I'm saying this morning. The ruptured and unruptured aneurysms, we're not going to talk about ruptured aneurysms. That's fairly straightforward. We treat them, and it's just a quibble about how we do that. So mostly I'm going to be talking about unruptured aneurysms. And to think about indications for that, you need to think about what goes into the natural history, what goes into the effectiveness of your treatment, how effective your treatment is, and what the risk of that treatment is. So those are the three components that we'll be talking about. In terms of thinking about the natural history, the first thing to think about is the prevalence. How prevalent a problem is this? And if you look at large meta-analyses, the prevalence is estimated somewhere around 3.2% for a population normalized to a mean age of about 50. So lots of aneurysms out there in circulation. There are a lot of conditions associated with aneurysms, polycystic kidney disease, probably the best known, Ehlers-Danlos, all of the connective tissue disorders, things like coarctation of the aorta, Loeys-Dietz, a relatively new described collagen vascular disorder that you may hear more about, neurofibromatosis, lots of conditions with their own sort of special circumstances that drive both probably more aggressive treatment in a lot of the conditions, but also more technical challenges, so more risk for treatment in the equation. There is a familial genetic component to aneurysms, and depending on what source you're looking at, it's somewhere between 70 and 20% of aneurysms have some familial component. And if you start screening families where there's more than one family member that have an aneurysm, you'll find somewhere between roughly 10 and 20% of first-degree relatives will also have aneurysms. So you should keep that in mind as you're seeing patients. On the flip side, if you have a sporadic aneurysm and you screen the family, then it's probably about 4% of first-degree relatives you'll find have aneurysms, which is pretty darn close to that prevalence number of 3% that we started out with. So clearly sort of two distinct groups, familial and non-familial. There was a very large NINDS familial intracranial aneurysm study looking at all kinds of genetic components for aneurysms and trying to sort this out a little bit, and lots of interesting reading around that. And in that cohort, they found that if there were two siblings, siblings seem to have a higher concordance, or three family members, then you could find aneurysms in almost 20% of first-degree relatives. So it is something I don't think I really fully appreciated or paid enough attention to, the familial aneurysm story. And yeah, that's and I think what has changed my sort of thinking about that in the last year was a project we did over the summer. I had a Gonzaga intern here over the summer and had him look at Native Alaskan aneurysms. We happen to have a contract to look after the Native Alaskan patients. So a lot of the patients with aneurysms come down here because in the Alaska Native Medical Center, they don't have a vascular surgeon. So the patients come down here, and we started noticing, or it was always there, of course, but noticed that if you talk to these patients, they had a very common theme was that they had relatives that had also had aneurysms. And so we started looking at how frequent the family history was in the Alaskan Natives versus our general population. And it turned out that in the Alaskan Natives, there was a positive family history in 42% of the patients, whereas in our general population, you could only draw that out at about 18%. So it looks like it's double with an odds ratio somewhere around over 3 for increased familial aneurysms in the Alaskan Native population, which is kind of interesting because it hasn't been described before. And what goes along with that is that the multiplicity is off the chart as well. So they're much more likely to have multiple aneurysms, and they're twice as likely to have MCA aneurysms as other locations. So something about familial aneurysms, and this has been demonstrated not as strongly in other studies, but in other familial studies, it seems like MCA aneurysms are more disproportionately represented. Um, all of this is linked to female sex, of course, smoking, hypertension, and history of family vascular disease. And so the general recommendations for screening, have been, and whether that needs to be revised for certain populations, is that if there's more than one family member with an aneurysm, then they should be screened. Certainly, people with polycystic kidney disease should be screened early, and other things like coarctation of the aorta and other high-risk populations. So then moving on to predictors of rupture. Clearly, there are subsets of patients who we think are more at risk than others, and very consistently across studies reported is the size of the aneurysm as a risk factor and a history of prior subarachnoid hemorrhage. Less clear, but probably implicated in terms of increased risk, are patients that are having onset of aneurysms at a younger age, smoking history, and the morphology of the aneurysm. Less clear still, hypertension, and the family history of subarachnoid hemorrhage we've talked about, you have to separate out that familial versus the sporadic version. Growth of aneurysms, how much of a factor is that? There are a couple studies fairly recently looking at the risk of future rupture in aneurysms that have been documented to grow. In this paper, it was almost 20% annual rupture rate, so clearly a concern. This paper out of UCLA said a 2.4% rupture rate, but the reality is that those patients just didn't get followed. Most of us are uncomfortable sitting on an aneurysm that's growing, and in this study it was pretty clear that the aneurysms that were identified as growing were fairly promptly treated. What was surprising to me in this study was that they had a much higher rate of growth in aneurysms that they were following conservative 18% than what's been my experience. It seems, to patients I follow, it seems like it's much less frequent that the aneurysms are actually documented to be growing. Factors limited to growth, again, the female sex, smoking, younger age, alcohol's implicated. Multiple aneurysms seem to be worse. What about symptomatic presentations? Very increased risk of hemorrhage in patients that are presenting symptomatically. So fourfold risk in this meta-analysis. And then the ISUIA International Study of Unruptured Intracranial Aneurysms is a fairly old study that I bring up every time I talk about this, just so I can say bad things about it. It's a study that gets quoted an awful lot and has gained an awful lot of credibility. It's published in the New England Journal. And there are useful things in it, but the important thing to really remember about that study is the selection of the aneurysms. And the aneurysms were very deliberately selected for conservative management. So all aneurysms were selected as aneurysms that somebody thought were, either just low-risk aneurysms based on whatever gestalt they had, or they thought the aneurysms were just not safe to operate on for some reason, maybe older patients, whatever. But they were not random aneurysms, assigned to one treatment or the other. They were aneurysms that were selected because not treating them was thought to be the right thing to do. So the study gets a lot of credibility because there was a retrospective arm, but then there was a prospective arm as well. And it's sold as a prospective study, but it doesn't matter what you do if your patient selection up front is flawed, not just flawed, but deliberately targeted at one particular population. You can't then apply the results to other aneurysms. You just can't fix that. So there are lessons to take from that. But when you see it quoted and I think misused in documents that promote conservative management, I think that's just a misuse of the data. But there are things, that, as I said, that are useful in it. The prospective arm, what happened to those patients once they were treated, those sorts of things. We didn't have that kind of data with that large a population sample before, so that was useful. And they started drawing attention to size of aneurysms, particularly small aneurysms that are getting treated, and picked 7 millimeters as a cutoff point, and found that for incidental aneurysms, if they were less than 7 millimeters with no prior history of aneurysms, then there was a very low rupture risk. But if patients had aneurysms greater than 7 millimeters in a prior history, that had a big impact on on the risk of future hemorrhage. And so my, thinking once again that the aneurysms were selected because they were low-risk aneurysms, despite that, you saw that their 5-year cumulative risk, cavernous, obviously going to be a very low rupture rate, but anterior communicating, middle cerebral, internal carotid, this number was, kind of surprisingly low for people who treated aneurysms in the past. When we started getting the posterior circulation, even with these aneurysms being selected for conservative management, you started seeing numbers that were more sort of in keeping with what people believed. Aneurysms that had no prior history of rupture, slightly less than aneurysms in patients that had another aneurysm that had previously ruptured. So this number was getting, close to that sort of 1% per year number that was more commonly believed. The other thing that ISUI did, again, despite the selection bias, certainly showed the impact of size. If you had aneurysms, breaking them up between 7 to 12, and sort of medium size and large aneurysms, when you get to the large aneurysms, particularly posterior circulation, 50% 5-year rupture risk. So clearly bad aneurysms. Even in the over 12 millimeters, you were looking at 18% over 5-year rupture rate in the posterior circulation. And even the anterior circulation, in this category, pretty clearly a high-risk population, even among aneurysms that initially are selected for conservative management. But given the selection bias, those numbers are probably low. When you start looking at meta-analyses for small aneurysms, we're stuck with that paradox that frustrates so many of us, that the aneurysms we see that come in ruptured are small. But when you start looking at incidental aneurysms that are under 7 millimeters, the rupture rate seems to be very low. And this meta-analysis suggested less than 0.5% per year for small aneurysms overall. They looked at a lot of studies, a lot of patients. They did find some things that stand out, higher risk of future rupture for age over 60. Again, females as usual, Japanese and Finns catch kind of a bad rap when it comes to aneurysms. They seem to be significantly at higher risk. Excuse me. And then symptomatic, I've already mentioned the higher risk for if the aneurysm is presenting in a symptomatic fashion, a much higher risk, larger size, posterior circulation, all of these seem fairly consistent. There was a Norwegian study which I think was kind of slick in looking at trying to get at the whole population of both the prevalence and the risk of those aneurysms rupturing. Again, trying to get around this paradox of small aneurysms not rupturing and yet seeing small aneurysms ruptured. And they just selected randomly over 1,000 MRAs of MRAs that were done for reasons other than concern for aneurysms. So incidental aneurysms picked up randomly on MRAs. Saw a prevalence of around 2% in their population, which is a pretty normal number. But they had a subarachnoid hemorrhage rate of 16%. And from that, they're able to calculate roughly 1% per year in their population of aneurysms, incidental aneurysms rupturing. When you sort of look worldwide at the prevalence of hemorrhage, the general number is about 9 per 100,000 rupture rate from aneurysms. But in Japan, it's pretty much double that. Same in Finland, as we just saw. But in South America, it's half that. So you get this average, again, 9 or 10 is kind of a number to carry in your head. Half that in South America and double that in Japan and Finland. Japan has a lot of good population data as well. One of their recent things they did was the Unruptured cerebral aneurysm study, where they looked at almost 7,000 patients and followed them for a little over a year. And they saw in the Japanese population an annual rupture rate of 1%. Strong correlation, as with every other study, with the size of the aneurysm. They certainly did see the small aneurysms rupturing, but pretty infrequently. And then when you get up to the giant aneurysms, pretty much a third of them rupturing in a year. So a worse number certainly than we're seeing in ISUI. Unselected aneurysms is the difference, and possibly that genetic component from the Japanese population. ACOM and PCOM were higher risk in a daughter sac aneurysms were a higher risk. So now we've talked about the prevalence. We've talked about a little bit about the rupture risk of incidental aneurysms. Now we have to think about the treatment. What's the risk of treatment? That's what we're balancing it against. And we have to think about the efficacy of that treatment. It doesn't matter if the treatment is safe if it doesn't work. And you can talk about conservative management following the aneurysms, open surgical treatment, and then endovascular treatments. So conservative treatment, if you are going to follow an aneurysm, you need to talk to patients about smoking because there are modifiable risk factors. And hypertension is clearly important to treat it. Statistically, it's been harder to quantify that. Again, out of Finland, where you have a captive patient population because of the healthcare system, looked at patients that came in with incidental aneurysms versus ruptured aneurysms, same patient population, of course, and the patients who were presenting with their aneurysms ruptured had a much higher rate of being either non-compliant or not on antihypertensive medicine. So you took the two groups, and the difference between the ruptured and the unruptured patients was that the patients with unruptured aneurysms were on antihypertensive medication. So a little bit of an end run to sort of get at the hypertension. Alcohol also a factor. So your patients, if you're following conservative, you need to talk about alcohol, blood pressure management, and smoking. Now let's talk about open surgery. I don't want to talk about clip coiling too much because that comes later in the day. But you do have to think about the effectiveness and the risk of the treatment. So you do have to think about what the difference is between endovascular and open treatment for aneurysms. And there are lots and lots of studies and lots of ways trying to get at the numbers. A lot of single center series with amazing results, usually retrospective, but generally poor quality studies just because they weren't controlled, they weren't independently evaluated, and those sorts of problems. So you can certainly, when you try and do a meta-analysis of this, the real complaint of that meta-analysis was the absence or shortage of high-quality studies to draw from to do a legitimate meta-analysis. This one from Kotowski, though, in 2013, suggested about a 1.7, roughly 2% mortality and 5% morbidity from surgical clipping. And when you start looking at a bunch of other databases, you start seeing numbers. This is drawn from the National Inpatient Sample data published in 2005. Again, somewhere in that 1 to 3.5% range mortality, somewhere north of 13% for morbidity. In the ISUI, as I said, there was a prospective arm in that where aneurysms that originally selected not for treatment went on to be treated. And in those, they had a roughly 2% mortality, 12% morbidity at the 1-year time point. Size matters in terms of treatment, just as it matters in terms of risk. So you're always balancing that increased risk of the aneurysm versus the increased treatment risk. They go up in parallel. And if you look at anterior circulation for non-giant, and this meta-analysis really pretty low mortality, morbidity numbers. If you get to the posterior circulation, giant aneurysms, your 10% mortality, 40% morbidity. So size, location, very, very important in that decision. What about the efficacy of clipping? Certain people I have worked with seem to believe that it's 100%, works every time and leaves no remnants. But if you look at a larger series, I think this is probably a fair number, that somewhere in that 90% range of aneurysms are well clipped, are without a neck remnant, but it's not 100% either. So those, and certainly those patients who have a neck remnant, who have residual aneurysm, also need to be followed and should not be considered completely occluded. In series we looked at in Phoenix for post-clipping recurrence, the aneurysms, the normal saccular aneurysms that were completely clipped really had a recurrence rate that approached 0. And the aneurysms that on post-treatment angiography that looked completely occluded but recurred were almost always aneurysms that were different, some sort of fusiform, something not a straightforward saccular aneurysm. So I think you do have to recognize that, number one, you need to check after clipping that the aneurysm really is well occluded. And if it is well occluded, I think it is fair to say that the recurrence rate for a typical aneurysm is exceptionally low. In terms of getting back to sort of larger population-based studies looking at the risk of larger studies that have tried to compare coiling and clipping outcomes in terms of morbidity and mortality. The problem with these studies is you really have to remember that although the numbers fairly consistently favor coiling, they're not apples-to-apples comparison. They're different aneurysms that are selected, just like the ISU-IA studies. It's a selection bias problem. But there are some things that become sort of common themes through these studies. One is generally that the clipping has a higher odds ratio of an adverse outcome versus coiling, and that tends to go up for age. And here you see in this large series of odds ratio of 4 for adverse outcomes for clipping, being more likely to have an adverse outcome as you get older, particularly over 65. Higashida looked at over 2,500 patients from the non-federal hospitals. The database that's publicly available there, adverse outcomes roughly double in the open surgery. Another large database from the National Inpatient Survey, roughly double adverse outcome. Brzezinski, another view of over 64,000 patients, the national outcome, roughly double the rate of adverse outcomes in unruptured aneurysm. More recently, McDougall has looked at a prospective propensity-matched series where they did try and account for differences in the patients and saw that ischemic complications were more than 3 times likely in the open surgery, and the risk of being discharged to long-term care, there was an odds ratio of almost 5. So there clearly does seem to be something there in terms of increased risk for open versus endovascular. And the question is, do the differences in efficacy counterbalance that? And we're still trying to get at that, really. This is one of the larger meta-analyses of unruptured aneurysm endovascular results looking at occlusion. So this is trying to get at efficacy. Are the aneurysms well occluded? And in this meta-analysis, a satisfactory occlusion, not a particularly satisfying term. At 86%, these are going to be self-reported, not adjudicated. And in almost every study, when there's been a practitioner reported versus a core lab reported, the number of residual aneurysms generally doubles. So we aren't very good at looking at our own images. But despite that, the aneurysm recurrence was 24%, so dramatically higher than the surgical clipping. Retreating in 10%, again, dramatically higher. Rebleeding a little, at 0.2%, not that much higher despite the frequent aneurysm recurrences and remnants. But one thing we do have in the endovascular side of things are randomized trials. There are at least 3 trials of over 500 patients that were done randomized prospectively, randomized into different coils, so it's not helpful in comparing clip versus coiling, but what it does allow you to get at is the safety and a little bit of efficacy of the procedures. So there are these 3 trials. There are some others coming out, and there are some pretty large, not randomized trials, but prospective databases, particularly out of France, that have really done, I think, a pretty good job of looking at the safety. And for obvious selfish, self-aggrandizing reasons, I'm going to talk about the MAPS trial, which was one of those 3 trials that I was involved with. It's just that I know it the best, and all 3 trials in terms of what we're talking about in terms of safety and efficacy are remarkably similar. So this was a trial that ran with 5-year follow-up, and that's the other advantage of this trial, was that none of the other trials have a longer-term follow-up. 5 years isn't long enough, but it's longer than anything else that is out there. We had over 600 patients. The results, angiographic results, were core lab adjudicated, and the primary outcome was target aneurysm recurrence, which we defined as retreatment, sudden unexplained death that could have been due to subarachnoid hemorrhage or rehemorrhage. So any of those events was a treatment failure, a target aneurysm recurrence. And the reason I'm talking about this trial are the outcomes, and we saw that for the whole cohort, which included ruptured and unruptured, we saw that patients were independently assessed, unchanged after the procedure in more than 90% of the cases. So relatively low morbidity of the treatment. And if you look at unruptured patients, at the end of 1 year, they had a good outcome clinically, modified Rankin, in basically 96% of patients. So, that gets to the safety of the procedure, that a very small, too many, but a very small number of patients are hurt by the procedure. And you can say that, patients that we select to put into trials are probably more typical aneurysms. They're not the freak show aneurysm. Nobody's going to enroll that in a trial. So it may not be representative of all aneurysms, but I think of the standard aneurysm that we treat on a day-to-day basis, it's pretty representative. And this is the weak spot here at the bottom. The target aneurysm recurrence in the two groups was essentially the same, which was, ostensibly the point of the trial. But really, what the value of the trial is that, it reveals that we have this target aneurysm recurrence failure rate of somewhere close to 14-15%, and that's pretty significant compared to clipping. So we have to own that. And one other thing that came out of this that is very useful is that the Ramon score at the end of the procedure, so immediately after the procedure, is the aneurysm got complete occlusion, residual neck, or residual aneurysm filling, which would be a grade 3. That, as judged by the core lab, was very strongly, high probability, p-value 0.0001, predictive of failure of the aneurysm, recurrence, retreatment, rehemorrhage. So if you had Ramon 3 filling at the end of your treatment, then you have 25% risk of target aneurysm recurrence within 5 years. Interestingly, you look at when does that happen. This is the year count here. This is the number of aneurysms retreated, and you see that in the years 3 through 5, almost no retreatments occurred. The retreatments were very much front-loaded to year 1 and year 2. A weakness of the trial was that we didn't force follow-up imaging at year 5. You had to have imaging at year 1, and then after that, it was sort of standard protocols. They were all followed clinically to year 5, and if people were imaged, they had a higher chance of being retreated later on in these last 2 years, but presumably people being imaged are the ones that you're more concerned about, so there's probably a little bit of a bias that way. But the point is that you're able to identify really at the time of treatment the patients that are most at risk for being retreated. Now the criticism here is that you're self-selecting. You're looking at that, you're seeing residual aneurysm filling, and you're retreating it, so it's a self-fulfilling prophecy. And that's largely true, except that we had 5 aneurysms that bled. 3 of them were in the ruptured group and bled during the initial hospitalization. So they come in with a hemorrhage, they're coiled, and within a couple of days they bled, so the first hospital admission. And then after that, for the subsequent 5 years, no additional aneurysms in the ruptured group bled. So that's pretty good efficacy in terms of preventing future hemorrhage. But in the unruptured cohort, which was over 400 patients, there were only 2 hemorrhages. Both of those occurred in a delayed basis, this one after 540 days, this one after 340 days. But the common theme here is that there was no difference in which coil we used, but what the common theme is that at the initial treatment based on core lab adjudication, they all had Ramon 3 filling. So no aneurysm in that trial, over 600 aneurysms, bled if it had initial treatment achieved of grade 1 or grade 2 occlusion. And I think, and that correlation again with the core lab, not so much with the self-reported, because the self-reported results were so much better than the core lab reported. So I think the take-home message from that is that you need to be hard on yourself and honest on when you're looking at that initial post-treatment angiogram. You need to really make sure you're getting Ramon 1 or 2 occlusion, and you should think about that case before you start. Can I get to that degree of occlusion, or am I looking at this aneurysm and say, well, that's really hard, I'm just going to throw a few coils in there, and I know there'll be some residual filling, but that's okay. I think this is telling us that that's not okay, that you really want to get to that grade 1 or 2 occlusion, and that's going to help a lot to prevent these post-treatment hemorrhages. Just for a little bit, to be fair and balanced, the Ceresite trial was a similar trial comparing 2 different coil types, and what I want to show with that is just their outcomes in terms of discharge status, unruptured aneurysms, 98% basically, MRS 0 or 1 post-treatment. They had 500 aneurysms overall, most of them unruptured. And you know, an MRS modified rank score of 2 in the remaining patients. So nobody after treatment in the unruptured aneurysm went to a modified ranking of 3 or worse. So amazingly safe outcomes. They had no deaths. 98.5% of their patients in this, you know, multi-center trial went home, not to rehab for elective aneurysms. So I think that shows that it's safe and generalizable because this is across multiple centers, multiple practitioners. And I've lost track of the time here, which is so. Whatever we would like to see, of course, is a randomized trial, clip versus coil, for unruptured aneurysms. We've done that a couple of times for ruptured aneurysms, never done it for unruptured aneurysms. The Canadian Unruptured something or other in aneurysm trial, I forget what CURES was the acronym, has tried to do this. They've been trying to enroll patients for over 6 years, and just a couple of weeks ago they reported their results as they are so far. In terms of aneurysms that were randomized to clip versus coil, unruptured patients, and they're struggling with enrollment. They had 136 patients enrolled in that time period. And this trial, their primary endpoint is treatment failure defined as residual aneurysm filling. I don't think you need a trial to know that there's going to be more aneurysms in the endovascular group that have residual aneurysm filling. So this is a trial that's sort of designed to fail from the endovascular. But the real question is, in my mind, you know, what happens to those patients? How many of them actually, how protected are they, and how many patients are hurt up front by the open surgery versus the endovascular, and is that price too high a price to pay for getting to a higher rate of occlusion? Way too small a sample size to make any sort of intelligent comments about that. In their treatment failure, in other words, residual or aneurysm were retreated, clip versus coil, 5 out of 48 for the patients with 1-year follow-up, 10 out of 56. You know, looks like double, but it's not large enough sample to be statistically different. Their 1-year morbidity mortality, which I didn't quite understand, is the same clip versus coil. And the reason I don't understand it is because they had new neurological deficits in almost 20% of the clip patients versus, you know, less than 10% in the coil patients, and that was statistically significant. So I don't know how you get this many new neurological deficits and then at 1 year the patients are all the same. But you know, presumably they were mild deficits that patients did recover from, but in other trials those deficits haven't been so mild. So I will finish. There is hope. And the question is kind of how do you put this all together? Because it is overwhelming, you know, all these studies, and you sort of, I'll bombard you with them to sort of show that there's more, I think, consistency among the trials than differences, and whether the numbers, you know, are 3% or 3.4%, it doesn't matter. The sort of directions are pretty consistent. And I'm not smart enough in my own mind to put all that together, and so I use crutches. And 2 of the crutches I use are the phases scoring and the unruptured intracranial aneurysm treatment score, which we'll see next. So the phases scoring was an attempt to put together all of these factors. So it looks at the populations that are higher risk, Japanese and Finns, things like hypertension, patient age. I know that's small and hard to read. The size of the aneurysm and other factors, and just scores them. So each factor has a score, and then you just put it on the curve. And you put the score of the aneurysm here, and this tells you the 5-year risk rupture. And again, I know it's way too small here, but it tells you that, if you've got a phases score of 10, your 5-year risk rupture is around 5.3%. So then you can, say to the patient, roughly, as much as we can sort of individualize it for you, your 5-year risk is 5%, 10%, whatever it is for that patient, to try and individualize it a little more, because the general numbers just are, really are disservice to patients if their conditions don't match that general average aneurysm. So that's their risk, their natural history risk. You've got that. And then you look at the treatment score, whether the aneurysm should be treated, which is the unruptured intracranial aneurysm treatment score was something that Nima Etteman organized this consensus group. There were about 40 or 50 people who treat aneurysms, neurointerventionists, neurosurgeons, neurologists, who got together and talked about what factors they used to make a decision into whether or not to treat an aneurysm. And then they weighted them, scored them, had the consensus document generated, and then validated among people who also treat aneurysms but weren't involved in the development of the scale. And and what you end up with is this sheet here, which again I know is too small to see, but it just lists all those things we've been talking about in terms of aneurysms risk, both of rupture and risk of treatment. And there's 2 columns. Scores that you add in this column are scores in favor of treating the aneurysm, and points accumulated in this column are in favor of conservative management. And then it's just if there's a big difference between the scores, that can help guide you and your patient one way or the other. It's broken down into 3 components. These are the patient components, so things like the age, their particular risk factors, their life expectancy, comorbid disease, and all these things. So like a comorbid disease would be weighted towards not treating. A young age would be weighted towards treating because of the longer risk exposure. So those are the patient factors. The aneurysm factors, the size, location, the morphology of the aneurysm. And then the treatment risks. Again, age is a treatment risk, so that ends up in this column if they're older. The size risk goes up, so that ends up in larger aneurysms, give you points for risk. And they're spotted treatment, since no treatment is without risk, you're spotted 5 points there. So how does this look? Let's say you have a 58-year-old smoker, otherwise well, has a positive family history for aneurysms and an 8mm basilar tip. Should that be treated or not? Look at the aneurysm. 58-year-old smoker, treat it, yes or no? I got 1 yes, 2, 3, 4. All right. So let's look what the scorecard says. Scorecard says they get points. Here's for the age points. That's too small for me to see as well. But these are all the factors. So smoker, family history gets you points there. And as you go down the columns, you end up, the size of the aneurysm, location gets points. You end up with a score saying 16 in favor of treating, 8 versus conservative management. So that's a huge difference there. So this group of people, their consensus would have been to treat this aneurysm. So you're in agreement there. That's the aneurysm treated. That's the aneurysm 5 years later. Okay, let's have one more example. 67-year-old, a woman, smoker, hypertensive, 7mm aneurysm. So it's right at that cusp of sort of small to medium size according to ISUIA. ISUIA says that this aneurysm, is pretty low risk for rupturing. And the patient doesn't have a family history or other particular high-risk features. The aneurysm is not lobulated. The 3D of the aneurysm looks like this. So I think it's a little bit complicated because of the way the branch vessel comes out of the aneurysm. So what do you think? Treat or not? We're not talking about how to treat it. We're just talking about whether or not you would tell this 67-year-old woman to have her aneurysm treated. Everybody's going to treat it? Okay. So the scorecard gets her 2 points for her age. She's a cigarette smoker. She has high blood pressure. That gets her 5 points for treating it. Doesn't have any chronic conditions or comorbidities that would preclude treating it. She gets 2 points for the size. As I said, it's a smooth aneurysm. age-related, she's a little bit older, over 60. She gets 3 points for that in terms of her risk. The aneurysm size gets her 1 point. The complexity gets her 3 points, and you're spotted 5. So the consensus group would have said follow that one conservatively. And oddly enough, I have no treatment pictures for her. So it's not meant to be followed dogmatically. It's meant to be sort of a gut check. We all, if you strongly don't like the score or don't agree with it, you can, it just gives you a pause to sort of think about that and see if you're an outlier in terms of being too conservative, too aggressive. And the last thing that I want to talk about are knowing your own data. And it's very, very hard to know your own data and your own numbers and whether you're doing a good job or not. And you think it's easy because you remember the bad outcomes, and depending on your personality, they're either disproportionately big or you forget about them, and those are our spectrum of our people. But either way, it really is very hard to be objective about whether or not you're doing a good results. And so I would encourage you to really track your results. And one of the ways that we're doing that here is the Neurovascular Quality Outcome Database, and this is set up by the AANS, and it's been around for a long time for spine. It's really just getting started for vascular. There currently are, I think, about 15 places enrolling it. We started. It took a long time. It takes resources. You have to have a person abstracting the data, and it takes a lot of work, and that costs money, and your institution doesn't like spending that money. But ultimately, knowing your outcomes is incredibly empowering because it tells you what you need to fix if you have a problem, and you get to point out the good results if you're having them. So we started enrolling patients here. The first patients enrolled in nationwide was just in 2015. We started enrolling patients in January of this year. There's about 15 centers nationwide. The nice thing about this, obviously you can track your own data yourself. The nice thing about this is that you can benchmark it against the national norms in a blinded fashion. To participate, you have to have aneurysms, all aneurysms you treat, all strokes that you treat endovascularly, all AVMs, carotid stenosis treatments, and intraparenchymal hemorrhages all have to be tracked. This is our first 6 months data for unruptured aneurysms. We had 26 clipped, 31 coiled, and knock on plastic. We had excellent outcomes for that. So that's something helps us a lot in terms of dealing with our administration and our patients, saying that these are our numbers, not somebody else's numbers from a population-based study. So we're not perfect in our knowledge of the natural history, the treatment risks, treatment efficacies. I think open surgical treatment of intracranial aneurysms is very highly effective, but it has a higher morbidity and mortality rate than endovascular treatment. Endovascular treatment can be accomplished with a low rate of morbidity, but we have a higher recurrence rate, and we have to be open about that. And what's been gratifying in the long-term studies, like MAPS, is that it really doesn't look like the delayed hemorrhages are going to overtake that upfront lower morbidity. So I think that's a positive in terms of the endovascular treatment.